Welcome, everyone, and thanks for joining us. This session is called Tying It All Together. I'm Caroline Richardson. I am the MCT2D Program Director. Here are our learning objectives for today's session. And disclosure of relevant financial relationships. I do have a grant with Dexcom. And here's our agenda for today. We're going to talk about low carbohydrate diets, and particularly the effect of low carbohydrate diets when you're talking about different medication combinations, and what to do about medications such as insulin when you start a low carbohydrate diet. We're going to talk about combining medications with low carbohydrate diets, including SGLT2 inhibitors and GLP-1 receptor agonists. And we're going to talk about continuous glucose monitoring to reinforce low carbohydrate diets and medication changes. Most of today's talk is going to be case studies to help us understand how to put these things together in real patients. Finally, at the end, we'll go over some resources for clinicians and patients. So first and most important lesson from today is to start with diet. Eating too many carbohydrates is going to undermine all of the other strategies that we're trying to implement. In order to help a patient decrease their carbohydrate load in their diet, you have to start by understanding what they're eating. There's a number of ways that you can get at what patients are actually eating. The simple is just to ask them about their typical meals and snacks. Look for easy wins to reduce carbohydrates, such as substituting low carbohydrate vegetables for something that has higher carbohydrate load in it, or cutting out sweetened sugary drinks. We know that it's pretty difficult to help people change their diet, and educating people about low carbohydrate diet is maybe particularly difficult. And that many practices don't have the resources or people who are available to do the low carbohydrate coaching for patients. Part of our effort as a quality improvement initiative, as a learning collaborative, is going to be to learn from each other about how we solve and overcome the problems of helping patients learn about low carbohydrate diets. We're going to be creating provider and patient resources based on the needs that are identified by the collaborative. And each practice, we're hoping, will identify one person who can become an expert in low carbohydrate coaching and provide support and guidance for patients within the practice. Diet alone is not enough for some patients. Even though it's critically important to helping patients reduce their carbohydrate load and improve their diet, many patients, particularly those who are already on insulin, need medication to support their dietary change. One way we can help them is by getting them off insulin. Insulin drives hunger and carbohydrate cravings. That's really one of insulin's jobs in your body. Somebody who's on a lot of exogenous insulin and also producing a fair amount of insulin from their pancreas endogenously is not going to be able to cut out their carbohydrates because of their hunger and cravings. So the ideal approach as we're decreasing insulin would be to start a GLP-1 receptor agonist. GLP-1 receptor agonists will help cut some of those cravings, decrease overall insulin production over time, and allow people to lose weight and decrease their insulin resistance as well. SGLT2 inhibitors are also a possibility, but remember that people on very low carbohydrate diets or diets with less than 20 grams of carbohydrates per day should not be on SGLT2 inhibitor at the same time. It's risky for a number of reasons, and we'll go over those again in a minute. So when you start a low carbohydrate diet, you have to think about medication from the very beginning. And that's because as soon as people adopt a low carbohydrate diet, they're going to start to drop their blood sugar pretty rapidly. How do you decide how much to cut patients' insulin before they're starting a low carbohydrate diet? Well, really depends on how well controlled they are before they start their low carbohydrate diet. Those patients who are already well controlled at the beginning, you have to cut the insulin pretty significantly. We usually start by a 50% reduction in insulin doses in people who are tightly controlled and adopting a low carbohydrate diet. For patients who are poorly controlled, then we don't cut it as much because we want some of that improved control to bring them down into the normal range, but we still do usually decrease insulin somewhat. So one strategy that people use is if their hemoglobin A1C is less than 10%, or if their fasting glucose is, or if their glucose is less than 250, that's considered well controlled. It's not really well controlled, but it's not horrible. Then that's when you start by decreasing insulin by 50%. Stop sulfonylureas and other secretagogues that cause the pancreas to produce insulin. Continue other medications. Now, for those people who are very poorly controlled with the hemoglobin A1C greater than 10%, those people we don't want to cut quite as much, maybe by 25%, stop cutting the insulin, depending on how poorly controlled they are. But again, stopping the sulfonylureas and other secretagogues and continuing other medication. So, and let's just go over again very low carbohydrate diets combined with SGLT2 inhibitors. As we discussed, but this is just a reminder and a reinforcement, low carbohydrate diets can be either keto, or which is a very low carbohydrate diet, 20 grams of carbohydrates a day, or it can be somewhat low carb. And by somewhat low carb, we sometimes mean somewhere between 75 and 100 grams of carbohydrates a day. Those people who are on keto, a very low carbohydrate diet, 20 grams of carbohydrates a day or less, who are also on an SGLT2 inhibitor have an increased risk of euglycemic DKA, diabetic ketoacidosis. What that means is their sugar is not horribly high, but they're acidotic from ketones. And that's tricky because it's missed in the emergency room, it's missed in the primary care office. People who have been trained to look for DKA more traditionally are looking for very high sugars in the 600s, but a euglycemic DKA patient may have a glucose in 150 to 180 range and still be acidotic and still be at risk. The other thing is that when you do give somebody an SGLT2 inhibitor, even if you're not coaching them to eat a very low carbohydrate diet, they may choose to adopt a very low carbohydrate diet without telling you. Some people become pretty enthusiastic about the successes that they're achieving with a lower carbohydrate diet, and they end up really eliminating most of the carbohydrates from their diet without telling their doctor. So it's important when you start an SGLT2 inhibitor to tell the patients, educate them about the fact that the combination of a very low carbohydrate diet and SGLT2 inhibitor may be dangerous for them. All right. The other thing is that in patients, even on who are not on a very low carbohydrate diet, who've just decreased their carbohydrates somewhat to around 75 to 100 grams a day, who are also on an SGLT2 inhibitor, have to think about sick day planning. That means on days when they stop eating because they're not feeling well, because they're nauseous or vomiting, diarrhea, days when they're not drinking enough fluids, they have a fever and are getting dehydrated. It's really important that they know what to do to keep themselves from going into euglycemic DKA because of their decreased carbohydrate intake and because of the SGLT2 inhibitor on at the same time and their dehydration. So in general, for patients who are on SGLT2 inhibitors, they should know that on sick days when they're not eating and they're getting dehydrated, they need to work hard to increase their fluids, including water or chicken broth with electrolytes in it. Patients on SGLT2 inhibitors should stop the medicine during the days that they're not feeling well, not eating, and getting at risk of dehydration. Just don't take it. They won't need it. They won't be needing it to control their blood sugar because they're not eating those days anyway. So it shouldn't have any effect on their blood sugar to stop it for a few days. Don't stop the insulin. Insulin is a treatment for DKA, whether it's regular DKA or euglycemic DKA. But you may have to manage the insulin more tightly, more frequent checking of the sugars to make sure they don't go low on their sugar or high on their sugar, and adjust as needed. Some dietary options for patients who are trying to stick to a low carbohydrate diet when they're sick. And these are patients who are doing pretty well and not getting dehydrated and have stopped their SGLT2 inhibitor if they're on one. And they want to stick with lower carbohydrate foods on their sick days. They can eat some of these things: chicken soup without noodles, mashed cauliflower, chicken, fish, eggs, tea, and electrolytes without sugar in them. So we often use CGM to reinforce dietary changes. When you're adding an SGLT2 inhibitor or a GLP-1 receptor agonist to a patient's program, having a CGM on board really helps with making sure that any other medications such as insulin that are on board can be rolled back as needed as their glycemia drops. Whether that's because of diet or whether that's because of medication, it doesn't matter. So patients who have a CGM are able to learn what foods have carbohydrates in them more quickly and more easily than patients without a CGM. And patients who are adopting a low carbohydrate diet can adjust their insulin more quickly and more reliably as they're tapering their medications. So now we get to the point where we get to talk about some cases and some trajectories that patients might have. I'm going to start with sort of the big summary slide of what we're talking about throughout this whole initiative. This is a slide that takes a patient who has type 2 diabetes, is not particularly well controlled with an A1C of 8.2, is obese with a weight of 260 pounds, and is starting out on metformin, 1,000 milligrams twice a day, and a long-acting insulin of 20 units a day. And this patient can go take two different roads, and there's the top road and the bottom road on this slide. The top road is the more traditional approach to managing type 2 diabetes that's not perfectly controlled. The bottom road is the road that we're suggesting might be better for patients. And so let's first go through the top road and look at the traditional ways that patients might be treated if their A1C is 8.2 and they're already on insulin. Well, step one might be just to increase their insulin. So going from 20 units of insulin to 40 units of insulin, and maybe even adding some preprandial insulin that's shorter acting before each meal. And yes, adding insulin will improve that A1C. And as you can see on this roadmap, this patient who got extra insulin did decrease their A1C down to 7.6% at 3 months. But as he was decreasing his A1C, he was increasing his insulin, and that insulin drove up weight. He gained 10 pounds during that 3 months. And he was not perfectly well controlled at 7.6, so the insulin was increased again, 8 more units to 8 units at each meal. By 6 months, again, his A1C was a little bit better at 7.4, but he was up on a higher dose of insulin. Following him along for 6 more months up to the 12-month mark, very well controlled with an A1C of 7%, which is at target. But over the course of that time, with the higher doses of insulin, he's gained a total of 30 pounds. And in addition, he's up to 45 units of insulin and 8 units of short-acting insulin before each meal. He's gained 40 pounds and he doesn't feel very well. So while his A1C is good, he's not doing that well in other respects. So let's look at the alternative road, the road on the bottom of the slide, which is the road that uses the 3 strategies that we've talked about in MCTTD. Again, we're starting with a patient with an A1C of 8.2, and instead of adding insulin on top of his already existing insulin dose, we're going to start by focusing on diet, and we're going to also give him a CGM to help him manage his insulin as he's adopting a lower carbohydrate diet. Because he's starting with a lower carbohydrate diet and not that well controlled, we're going to reduce his insulin by about 20% down to 16 units a day instead of 20. And we're going to follow his CGM closely to make sure that we cut it enough to not make him go hypoglycemic. 3 months later, he's lost 10 pounds and his A1C is 7.6. Subsequently, he continued to work on his lower carbohydrate diet, continued to wear a CGM, but we added a GLP-1 receptor agonist as well. That further accelerated his weight loss, and we were able to reduce his insulin down to 10 units a day. And he continued to lose weight with a total of 30 pounds lost. By the end of 12 months, he was completely off his insulin, maintaining his weight with diet and exercise, and he had enough energy that he was trained to run a 5K next month. So that's the alternative path, and that's from at least from the perspective of the pathophysiology of type 2 diabetes, which is insulin resistance caused by insulin excess and weight gain. That's a much better path, is one where we're decelerating the disease by driving weight loss and reducing insulin dosing, reducing insulin resistance. And patients generally do feel better and have a better quality of life with less insulin and more weight loss. So here's our first patient case. This patient case is actually a video recorded patient case, and I'm going to go ahead and play it for you, and then we'll go on to some other cases which we'll have more discussion about.
I get up really early, I'm working later, I'm a lousy diabetic. I'm trying to be a better diabetic, and it's just so hard to be a better diabetic. Then it's, I guess I lack the, it's hard on me. So at the time, I was just thinking, I gotta be a better diabetic. And then this come along, I thought, wow, this will work out great. It was very helpful. She gave me, recipe ideas, lists on high carb foods, low carb foods, what to eat, what not to eat. I had the monitor. It has sort of made it easier to be more accountable. I had more of a goal to see that number all the time, trying to keep it down. When you see that number all the time, it's a lot easier than thinking, maybe it's a little number, I'll have a piece of pizza or something, and or if I had a half of one instead of a whole of one, then that made a whole lot of difference too. So, I went from 30 units on my insulin. I dropped all the way back down to 10 to what I was using when I first started taking the insulin. Would I recommend it? Heck yeah, I'd recommend it. I would like to get back on it, but I can't afford it. I don't think my insurance company covers it. I would like to see the insurance companies cover it, make it more readily available, because I got pretty much a lot of people in my family are diabetics. All my siblings, but like 2 are diabetic, and my parents were diabetic. My mother's parents were both diabetic. All her siblings were diabetic. And now I worry about my daughter. She's a plus size woman. Is she going to end up with it? And I'm thinking more than likely they're my 2 grandsons. I worry about stuff like that. Yes.
Okay, so that was Bob's story. We're going to go on to another case. This is James. James is a 61-year-old man. His weight is 287 pounds. His BMI is 37.9. He has type 2 diabetes and all the usual comorbidities. And his A1C is 7.8. It's not horribly controlled, but not at goal. Again, he's on 1,000 milligrams of metformin and 25 units of insulin, long-acting at bedtime. He does check his blood sugars with a finger stick twice a day, usually before breakfast and after his dinner. His fasting glucose is about 135. His postprandial after a meal glucose about 231. And he has symptoms. During the day, he feels like he has excessive hunger and cravings all day. Makes it hard for him to stick to the diet that he knows he should be sticking to. So take a minute and think about this patient's story and write down or just think in your head, what are your concerns for him and where would you start with him? Okay, so let's see what our options are. First of all, for concerns, we're not so concerned about his morning blood sugar. It's near goal. It's not perfect, but it's pretty good. The big problem for him seems to be his high after meal sugars, postprandial sugars, along with his daytime hunger and cravings, is making him hard to stick to a healthy diet. There's big swings in his blood sugar. It drops by 100 points from the peaks to his overnight lows. And that's difficult to control with medication. So where to start? We're talking about medications, continuous glucose monitoring, and diet. For this patient, partly because he was having symptoms and partly because he was having such big swings on his fasting glucose to his postprandial glucose, we started with a continuous glucose monitor. You can make a case for starting with either a lower carbohydrate diet coaching or with medication changes. But we wanted to see exactly what was going on with his glucose before we started to make those changes. We were a little bit worried that he might be getting hypoglycemic at night because that's a common problem. So here's what we found when he came back after a week of wearing his continuous glucose monitor. We had asked him to get a daily food log to go along with the continuous glucose monitor so we could help with interpretation. And what we found was there were a lot of peaks and a lot of valleys on his chart. And here is the first and probably most important finding, which is these episodes of nocturnal hypoglycemia. The red areas are all at night, and they clear up when he wakes up. But that nocturnal hypoglycemia is extremely common in patients with type 2 diabetes, and we never really know it's there with finger stick glucose. Only CGM can tell us. It's hard to test your sugar while you're asleep. And when we see this pattern of frequent hypoglycemia at night, we know it's going to be very difficult to control daytime sugars because there's a set of counter-regulatory hormones that get released when you have nocturnal hypoglycemia that make you have much higher sugars during the day that are hard to control. So step one for this patient has to be getting rid of those big red bars of hypoglycemia at night. And hypoglycemia as a general rule is always a result of too much insulin. It may be too much insulin made from your pancreas, so endogenous insulin. It may be exogenous insulin, but either way, it's too much insulin. Some other things that we're concerned about with this patient is the fact that he goes up, his sugars go up immediately when he wakes up in the morning, even before he's eaten anything. And that's what we call a Somogyi effect. And it is the effect of those counter-regulatory hormones on glycemia during the day. He does have postprandial hyperglycemia. You can see where he goes up into the yellow after he eats his meals, and that's to be expected. But some of those peaks are pretty high. You can see he goes up to the 350 range at times, and then after his peaks, he has a crash, and then we can see clear postprandial hypoglycemia about 2 hours after a meal. Sometimes he doesn't go all the way down into the red and it's postprandial hypoglycemia, but you can see it's a pretty big and a pretty fast crash from his highs after his meals, and that's going to be symptomatic. He's going to feel cravings and hunger when that happens. So our immediate plan of action was to reduce his insulin by 40% to prevent those episodes of nocturnal hypoglycemia that he was experiencing almost every night. Additionally, to address the fact that we're now giving him much less insulin and that his daytime sugars were so high, we need to start him on another medication to help with those postprandial excursions. We have choices of GLP-1 receptor agonists or SGLT2 inhibitors. And additionally, we could do a short-acting preprandial insulin, but we're really trying to get him off of his insulin, so we don't want to use that one. For this patient, the GLP-1 receptor agonist would likely lead to the most weight loss. GLP-1 receptor agonists and SGLT2 inhibitors have significant advantages as far as cardiovascular benefit compared to insulin as well. And we can use the CGM, we can continue to use the CGM to help him assess his progress on getting that postprandial glucose excursion under control. We started with an initial introduction to the ideas of lower carbohydrate eating and why he might want to do that, why it might make it a little bit easier for him to manage his sugars. And we started with breakfast. In particular, we wanted to replace his orange juice, which is a pretty heavy glucose load, with green tea, and he agreed to do that. Finally, at dinner, we asked him if he could cut out the carbohydrates in his diet and replace them with low carbohydrate vegetables, and he agreed to do that as well. At his next visit, we reviewed his CGM data again and continued to discuss his carbohydrate intake and its effect on his glycemic excursions. We further adjusted his nighttime insulin based on his fasting blood glucose, and we titrated his medications as well. Moving on to our next case, case number 2, Pamela Johnson. She's a 59-year-old woman. She weighs 250 pounds, has a BMI of 35.8 and an A1C of 8.2, so not well controlled, not near her target. She has type 2 diabetes and a hyperlipidemia, and she is also a former smoker, although she did quit recently. Looking at her diabetes medication, she's on metformin, glipizide, long-acting and short-acting preprandial insulin. She does do finger stick glucoses, checks again twice a day, testing before breakfast and after dinner. Her fasting glucose is 142, which is not perfect, but it's not horrible. And her postprandial average is again very high at 295. She also is symptomatic, experiencing daytime dizzy spells if she's active or if she misses a meal. That's sounding a little suspicious for possible episodes of hypoglycemia. The concerns with this patient are primarily those high postprandial glucoses and those symptoms of dizziness. And I guess finally, we would worry about the fact that she's been a smoker. She has poorly controlled diabetes. She's obese. She has pretty high risk for cardiovascular disease, adverse cardiovascular disease outcomes as well. So where to start? Again, with this patient, we asked about her current dietary habits. Breakfast, she said, I typically eat 2 slices of toast with jam, a bowl of oatmeal, and a glass of fruit juice. So toast, jam, oatmeal, and fruit juice are all almost entirely carbohydrates. That's a pretty high carbohydrate load breakfast, even for our typical American diet. For lunch, she grabs some food from the diner that she works at, like a hot turkey sandwich or some fried chicken tenders and some coleslaw. And for dinner, she's eating a lot of fast food, Arby's or Burger King, because she works pretty long hours. Sometimes she has frozen meals at home. Looking at all this, we can put together an estimate that she eats about 255 grams of carbohydrates a day, which is about half of her total dietary calorie intake. And much of that is focused on her breakfast meal. So from a plan of action perspective, we might introduce Pamela to eating low carbohydrate diets, particularly trying to decrease the carbohydrate load in her breakfast. We might want to get an even more detailed nutritional evaluation and get some help with nutritional coaching by referring her to a registered dietitian so that she can get longitudinal coaching on understanding what's in her diet, what it's doing to her blood sugar, and how she could substitute healthier foods. She agrees to try a low carbohydrate diet and make major changes in her daily diet, starting with 1 meal per day and gradually replacing the carbohydrates with healthier, lower carbohydrate options. For breakfast, we replaced her oatmeal and toast with a vegetable omelet. For lunch, she's been doing some meal prepping and carrying her lunch in with her, which is a grilled chicken salad with a balsamic vinaigrette. For dinner, she is also using her meal prepping skills and switching to some non-starchy vegetables instead of carbohydrates at dinner. Given all that we've just talked about, the dietary changes, the concerns about what's going on with her blood sugar, what medication adjustments would you make? So just as a reminder, when you're thinking about medication adjustments, remember that she is on metformin, glipizide, long-acting insulin 60 units before bedtime, and short-acting insulin 5 units before breakfast, 8 units before lunch, and before dinner. So now that we've changed her diet, especially focusing on her breakfast, what medication adjustment would you make? So here's what we chose to do. First of all, stop the glycoside. That's an insulin secretagogue. It's making your pancreas produce more insulin. That's not what we're looking for right now. We also are going to reduce her pre-meal, preprandial insulin by 50%. With each meal as we target the dietary change. So when she works on her breakfast, that's when we could reduce her preprandial insulin for her breakfast meal. If we then move on to lunch, then we'll reduce the preprandial insulin for that meal as well, until we get to all three of them being reduced. In addition to the preprandial insulin, we also reduced her basal insulin, her long-acting Lantus, by 20%. We instructed Pamela to check her blood sugar before each meal and at bedtime. So first follow-up visit. Pamela's been adjusting her diet, but her blood sugars are still pretty high. After further discussion, we figure out that Pamela's been able to cut some carbohydrates out of her diet, but not as many as we would have liked. She got down to about 180 grams a day. She's having trouble understanding what foods have carbohydrates in them and what foods don't, and what foods are going to make her sugar go up and what foods are not. So we started her on a continuous glucose monitor, so that she can actually see and get real-time feedback about her food choices. Again, a little bit more coaching on low carbohydrate foods and drinks and what would be appropriate for her to replace her current diet with lower carbohydrate options. She comes back at a next follow-up visit, and here's her continuous glucose monitoring from that wear period. Again, she's still high, especially right after her meals. She does have some periods where she's more in the normal range now. And so we talked more about her food choices and how to think about carbohydrates in her diet and what she can substitute. She does report that having the CGM is helping her to understand what food choices are doing to her blood sugar, and she wants to continue to use the CGM for a little bit while longer. So we give her another CGM, send her home, and here's her next follow-up visit. At this follow-up visit, she has been able to maintain a lower carbohydrate diet for about 2 months with the help of her CGM. She's already lost 10 pounds, and she's completely eliminated all of her mealtime insulin. Her basal insulin is down to just 30 units, down from 60 units. And she plans to continue the low carbohydrate diet and keep losing weight, and hopes to get off that basal insulin entirely. Her A1C has dropped down to 7.1%, much closer to the target range, and a decrease of 1.1% over 3 months. You can see on her CGM, she still has some peaks right around dinner time. So it looks like we can tell that her dinner time is still a struggle for her as far as her carbohydrate load goes. And we'll continue to work with her on that as well. Okay. One more patient here to go through, and then we'll have another video patient. This patient, Christina, is a 42-year-old woman. She weighs 192 pounds. Her BMI is 34. Her A1C is 7.1%. So she's actually pretty well controlled, very close to her target of 7% on her A1C. She has the typical comorbidities of a patient with type 2 diabetes, including hypertension, hyperlipidemia. And she is on metformin and empagliflozin, so a SGLT2 inhibitor that she's doing very well on, and she really likes it. Her glucose monitoring regimen is finger stick glucose, checking about once a day, usually fasting in the morning, and it's about 130, which is also very close to her target. On her own, reading on the internet, she learned about the low carbohydrate diet effects on diabetes, and she started to eat a low carbohydrate diet. So she's now on an SGLT2 inhibitor and eating a low carbohydrate diet and doing very well with her glycemia. She's not eating a very low carbohydrate or keto diet, so closer to 75 grams of carbohydrates a day. Eventually, she has some symptoms, a cough and some shortness of breath for about 24 hours. She sits down for dinner with her husband and realizes that her sense of taste is gone. Now she's getting worried. She calls her PCP's office PCP instructs her to get a COVID-19 test, and that test turns out to be positive. When she got her test results the next day, she was already feeling sicker, increased shortness of breath, malaise, lethargy, loss of appetite, and some belly pain and nausea and vomiting, all pretty typical symptoms of COVID-19, getting worse relatively quickly. Due to her lack of appetite, she really wasn't eating at all. She had a few sips of chicken noodle soup, but that was all she could get down. She started to get sicker, and her husband got worried and took her to the emergency room. Labs showed a glucose of 188, so not super elevated. Her serum bicarb was 16, her anion gap was 18. Her O2 sats were 94%, which was pretty good considering her COVID. They weren't too worried about her lungs, and a chest x-ray didn't show any major fluid problems or whiteout pneumonias that you might see in a severe COVID case. They did give her some Zofran for nausea in the office, or in the ER. What are your concerns about this patient, and what would you do next? Would you discharge her home? Would you keep her in the hospital? Is there anything else you might want to check? So the emergency room doctor was ready to discharge this patient to home, thinking that most of her symptoms were COVID-19 and that she didn't need to be admitted for COVID-19, that she could safely go home and be monitored. But while he's entering the discharge note, he notices that she's on SGLT2 inhibitor. He goes back in the room and asks Christina if she's been taking it in the last few days, and she tells him that she has. So the attending now has a suspicion that not all of Christina's symptoms are due simply to COVID-19. He reviews her labs and remarks about the bicarb and the anion gap, and realizes she may have an acidosis, a metabolic acidosis. So he decides to order a blood gas and a urinalysis and a serum beta hydroxybutyrate to confirm his suspicions. The blood gas does show acidosis. The urinalysis shows some ketones, and his serum beta hydroxybutyrate is elevated. So now the attending ER physician realizes that this patient also has not only COVID-19 symptoms, but also euglycemic DKA. So even though her sugar was only 188, she is in fact in diabetic ketoacidosis. And that's probably the combined result of her SGLT2 inhibitor use, her COVID-19 infection, dehydration, and a lack of appetite and not eating for several days. All of those things together dramatically increase the risk of euglycemic DKA. So instead of discharging her, he sends her home, and instead of discharging her and sending her home, he admits her, gets her hydrated, stops the SGLT2 inhibitor, and makes sure she stabilizes before he discharges her home. So next possible scenario for this exact same patient, I want you to just imagine an alternative scenario in which when Christina calls her PCP's office and her PCP tells her to get a COVID-19 test, that PCP also notes that Christina is taking the empagliflozin and asks Christina if she still has the handout that she gave her about holding off on the SGLT2 inhibitor when she's sick. Christina does not remember the handout at all, but the doctor reviews it with her and reminds her that she should be eating at least 50 grams of carbohydrates a day while she's taking the SGLT2 inhibitor to stay out of a risk of euglycemic ketoacidosis. Hold the SGLT2 inhibitor whenever sick. This would be a good time to not take the SGLT2 inhibitor until she gets her appetite back and feels better. Hold the SGLT2 inhibitor whenever you're not able to eat or drink normally, and including 3 days prior to any procedure that requires fasting, like a colonoscopy. After that reminder, Christina does get her COVID-19 test, finds out it's positive. She hasn't taken her SGLT2 inhibitor since she talked to her doctor. Her symptoms have generally been mild, some mild shortness of breath, a cough, and a low-grade fever. But she's doing pretty well. She doesn't have the severe belly pain or nausea or vomiting that she would have had if she had continued that SGLT2 inhibitor and gone into acidosis. Her food intake has been decreased due to her loss of appetite, so her blood sugar looks pretty good still, even though she's not taking the SGLT2 inhibitor. She feels confident that she'll be able to safely self-quarantine with her husband at home without needing any medical attention. So that's the alternate scenario that would be better for Christina and for the health system in general. All right, here's our last case. This is another video case, and this is Ruben.
Well, it kind of happened out of the blue. I passed out at Thanksgiving. I was concerned, so I went to the doctor, and when I actually was told that I had it, that was, there was a lot of things racing in my head, and after a while, I tried to get into the MOVE program. I had to do 6 months of classes, and I did that, and I was able to get into the program. So when I started the MOVE program, I was taking insulin and the metformin. I went onto the keto diet. It was a hard transition at first. Pretty much went through the house, got rid of everything. Initially, I felt kind of sluggish, but as I got into the diet, I actually felt better, had more energy. Initially, I lost probably, I'd say, 5 pounds within a week and a half. I was checking my insulin level with a patch that electronic patch they put on my arm, but I was checking it with my phone. And the great thing about that is it's easy. You just touch it to it, and it gives you readings, and the readings are sent via internet to the healthcare provider. People have to be aware of that. I found out is you can get your blood sugar way too low, and that's kind of what the beauty of being able to talk to your doctors, and then using the continuous glucose monitor, because they can see your peaks and valleys. So times where my blood sugar dropped below 100, if I started feeling off, which that only happened for maybe a 2 or 3 week period, because I was able to, in that time, through conversations with my doctors, to adjust my medications and my diet accordingly. I was doing this regimen for probably a month or two, and my through conversations with my doctors, found that there was no need for the insulin, because I had dropped my blood sugar almost 100 points within that time frame, just with diet, mostly with diet alone. So Dietary was kind of like one of the final steps. From going from the insulin to that, and alongside with proper diet, with the medication, brought my blood sugar down to a point to where I was able to get off insulin completely, and I was able to drop another 5 pounds, and then subsequently I lost 20 pounds of weight within a 6-month period. So it made me a believer in diet, and that's the best way to heal yourself, alongside with certain medications, where at one point you can get off of it altogether, which is pretty much the goal. Well, it kind of happened out of the blue.
All right, moving on. Those were our cases. I just wanted to talk a little bit about some resources that you can use in your practices for patients, and to get a better background and information about low carbohydrate diets, about continuous glucose monitors, about some of the medications that we're using. So the first set of resources is low carbohydrate resources, and there's 2 books that we use for patients. These are patient-facing literature that is actually pretty easy to read and understand. The first one is a book called Always Hungry. It's by David Ludwig, who is a pediatric endocrinologist at Harvard. The first 6 chapters of this book are explanation of the insulin hypothesis and what insulin does to your sugar and your fat cells. And then the last 6 chapters are some recipes that are higher in fat, lower in carbohydrates, and pretty easy to make with regular, usual household foods, and pretty simple, and things that people might like to eat that taste a little bit like comfort food, even though they're not the traditional high carbohydrate comfort foods. The Always Hungry book is a lower carbohydrate diet book, focusing on between 75 and 100 grams of carbohydrates a day. The Low Carb for Any Budget is actually a keto book. And that book is interesting because it's free. That is, if you go into Google and you type low carb for any budget, you'll find a link to the book. It's totally free. You can print it out, you can download it, you can put it on your Kindle, whatever, to read it. And you can, and it's a free book. It's keto, it's patient-facing information, very easy to read, nice pictures, well laid out with not just information about what you should and shouldn't eat, but also how to manage some of the side effects of a very low carbohydrate or keto diet. So those are the two books that we recommend for helping your patients understand the low carbohydrate and very low carbohydrate diet options. The low carbohydrate for any budget also focuses a lot on making sure you're not spending too much money on your food, because you can spend a lot of money on keto foods, but you can also do it at a relatively low cost. The last low carb resources for doctors or clinicians, low carbohydrate nutrition approaches in patients with obesity, prediabetes, and type 2 diabetes. It's a very detailed guide that talks about how to do low carbohydrate diets, what to worry about with side effects and how to manage those side effects, how to manage medication, and how to help patients adhere to a lower carbohydrate diet. It's a great resource for clinicians that are just starting out using lower carbohydrate diets in their patients. Finally, from a low carbohydrate perspective, there is the modules that are online and available for free and come with free continuing medical education around low carbohydrate keto diets. And so these 5 modules are a great introduction to how to help patients adopt and maintain a low carbohydrate diet. It does tend to be more keto focused than low carb focused, so very low carb, but lots of the information is valuable for either low carb or very low carb diets. And we're hoping that somebody at each practice will watch these 5 modules and become the expert or the champion for low carbohydrate diet coaching in their practice. Resources for medication are under construction. This is one of the more difficult things that we've tried to do as a consortium, because the issues around medications, not mostly around coverage by insurance companies of medications, are very complicated, and we're working on it. The medications are expensive. SGLT2 inhibitors and GLP-1 receptor agonists are very expensive. They tend to have either not be covered or have high copays for a lot of insurance companies, or there'll be one that's covered and the others aren't, and it's hard to tell which one is covered and which one's not. So we're working on a resource that we can use that will help providers and patients know what's covered by their insurance. Also, understanding some of the side effects and contraindications to these medications, sick day planning materials, etc. Those are all under development right now. And lastly, if you want to learn more about how to interpret continuous glucose monitoring, there's a user-friendly interpretation guide called The Role of Continuous Glucose Monitoring in Diabetes Treatment. And then there's also a primary care focused implementation of diabetes technology in primary care, which talks a lot about using continuous glucose monitoring in a practice that doesn't see a lot of CGM right now. So that is all of the presentation for today, but I think we will have some time for questions. Thank you.